All right, good afternoon, everyone, and welcome to the February Gravity Implementation Affinity Group meeting. I'll give people just a few more moments to join, and then we'll go ahead and get started. All right, good afternoon, everyone. Thanks for joining. Get started here in just a couple minutes.
Maybe it'd be a good idea if everyone kind of puts their name and their organization into the chat so we can get a better understanding of who all's here.
Yes, that would be great. All right, I see Sarah's joining. Awesome. All right. Well, it's a minute past on my end, so I will, without further ado, get us started here. So good afternoon, everyone. Good morning if you're on the West Coast. This is the February Gravity Implementation Affinity Group meeting. My name is Demery Henderson, and I'm the Grants and Programs Manager for Civitas Networks for Health. And I am not Sarah DeSilvi, Gravity's terminology director, who's usually kicking these off. But I am happy to be here today, and I'll be facilitating, and we're glad that you all have joined us. So we'll go ahead and get started. So here's our antitrust practices. Nothing news here if you've joined any Gravity calls in the past, but Gravity Project participants have the responsibility to comply fully with federal and state antitrust laws. And then just a few housekeeping reminders as we're getting started. So this meeting is being recorded and will be uploaded to the Affinity Group Confluence page following the meeting. And as a reminder to please mute yourself when you're not actively talking, and feel free to use the raise your hand function to chime in and utilize the chat features. I feel like people are already in there, which is great. So feel free to enter your name and your organization so we have a feel of who is in the room with us. All right, so here's our agenda for today. I'll start with a quick intro for our meeting, and then we'll move into the Gravity updates. And then we'll also be hearing from some representatives at Epic and Humana on the ROI and SDOH data exchange. And then following the presentation, there will be time for Q&A. And then towards the latter part of the meeting, Sarah DeSilvi, our Gravity Terminology Director, will facilitate our first community office hours, where the audience and implementers can ask open questions, and then I will wrap us up. All right, so before we get started with the bulk of our meeting, I just wanted to introduce myself if we haven't met already, and then quickly orient everyone to a few changes to the Affinity Group this year. So my name is Demery Henderson. I'm the Grants and Programs Manager at Civitas Networks for Health. I've supported the Gravity Project in various capacities for the past 4-ish years. But more recently, I will be formally supporting the Affinity Group presentations as part of Civitas and Gravity's partnership. So Civitas is a member and implementation partner of Gravity, and alongside the Gravity team, we will be facilitating the Affinity Group calls going forward. So as you can see from the visual here, it gives a nice demonstration of how Civitas fits into the Gravity ecosystem. So Civitas is, again, a member of Gravity and an implementation partner, and so we've been given the opportunity to become more involved and facilitate these calls. So thanks so much to the Gravity project team for being a great collaboration partner as always. Went too far here. So if you're not familiar with Civitas already, I will just give a brief overview of who we are. So we're a nonprofit, mission and member-driven organization focused on improving health outcomes for all through health improvement and health data exchange. And so our membership includes health information exchanges, regional health improvement collaboratives, quality improvement organizations, among others. And they're taking data-informed multi-stakeholder approaches to health improvement. And so at Civitas, we like to think of ourselves as the bridge between data and doing, and our members do incredible work, and Civitas helps bring that work to the national stage through our program portfolio. And so we're really grateful for all of our program partners, including the Gravity Project, who we work with on SDOH data standards implementation in New York, and all of those who help us bring attention to the great work of our members. And then lastly, before I turn it over to my colleague Corinne, I just wanted to note that the Affinity Group meetings are switching to quarterly instead of monthly, if you haven't heard our email blasts already. But they will continue to be at the same time. So the last Thursday of the month, 2:30 to 4. So our next meeting will actually be May 29th. And then you can see we'll have a meeting in August and then again in November. So we won't be meeting next month. We'll see you all again in May. And then I will now turn it over to my colleague Corinne for some gravity updates.
Great. Thanks so much, Demery. And I don't think I will need the full 10 minutes because I'm excited to get into our content from our presenters today. But my name is Corinne Bogan. I'm with the Program Management Office of the Gravity Project, which is Point of Care Partners. And just wanted to give a brief update to the group on just generally what's happening with Gravity project-wide and other opportunities that you can get involved in and plug in. So within our terminology work stream, we have weekly meetings on Thursdays from 4 to 5:30 p.m. We're kicking off our spring domains of person-level racism, toxic stress, and protective factors, and then planning for the fall as well with the domains of food access, neighborhood safety, and environments. And this is 3 more domains than we did last year, so we're really excited to grow in this area and have these important domains slated for 2025. Within the technical work stream, we meet bi-weekly on Wednesdays from 1 to 2 p.m. Eastern. We have an upcoming STU 2.3 publication of our implementation guide, and we'll be sharing more about that on our next public call, which is also paired with a discussion around a Gravity authored brief around the best practices for validating and documenting social diagnoses. This is a brief that Gravity released a few weeks ago, and we wanted to make sure it was socialized within the Gravity community, and we had the opportunity to hear from community members and receive feedback and just discuss it. So that's happening next Wednesday. And then further down the line in March within the technical work stream, will also be having a discussion and demo led by CCS Health on a use case we are exploring, which is referral for further. If you were in detail as well. And so this is kind of a follow-up from that session and a chance to be more involved for any of the vendors and the health IT folks out there that this is of interest to. And then lastly, Gravity is at HIMSS next week. I'm sure many of you have HIMSS on your calendar as well. In Las Vegas, we'll be participating in 3 sessions. So those are highlighted here if you want to see more Gravity and engage with us at HIMSS next week. Those can also be found on our Gravity calendar on the Confluence, and then links to all of our workstream specific meetings, the terminology implementation group and technical workstream public calls can be found on our Gravity Confluence as well. And I will drop that link into the chat here. And that's all I have in terms of Gravity updates. So I will hand it back to you, Demery.
Awesome. Thanks, Corinne. And now it is for the bulk of our meeting. We are really excited and honored to have representatives from Epic and Humana joining us today to discuss the ROI of SDOH data exchange. So I believe Matteo will be kicking us off from Epic, and then we'll be passing it to Glenn over at Humana. So Matteo, I will let you have the floor.
Well, thank you, Demery, and thank you to Gravity Project for, first of all, asking us to be presenting today, and we're happy to share what Epic has been doing in terms of being able to align with Gravity recommendation for SDOH data capture and data exchange. And then certainly very excited to have Humana present around how they are able to leverage all this technology for their efforts and to achieve very meaningful outcomes. So I wanted to really start here. Not all of you might be familiar with how we do SDOH data capture in Epic. So if we go to the next slide, for us to level set, I wanted to share that Epic has been providing technology to be able to capture SDOH information for several years now, since 2016, about 2016, 2017. And today our offering spans both the adult world and pediatric world, right? So in terms of the domains that we support out of the box. You can see those listed here. And of course, organizations that are on Epic can then extend this list based on specific needs for the organization. Next slide. now, capturing the data is great, right? But of course, since a few years ago, it is critical for us to be able to exchange this type of information as well. If you click one more time, and that is what Epic has been working on intensively in terms of being able to map all the SDOH information that we capture today, as well as exchange this data. And when I say exchanging the data, that includes between health systems, right? So if you are representing a healthcare system today, you're able to exchange this data with other hospital, but also with your payers. And this is a bidirectional data exchange. So payers are able to send insights back to health system and vice versa. Now, the data that we map behind the scene is those concept of domains that I showed in the previous slide, right? So we have mappings available to specific LOINC code sets to represent those domains, but also the individual question and answers that are used to assess a patient overall risk for that domain are mapped to LOINC codes. And we'll go a little bit deeper into that. But then the last piece I wanted to mention is that also when we look at interventions here in a couple of minutes, we map those to SNOMED codes as well, again, to provide the complete picture about the risk profile for the patient and the interventions that have been tried with the patient. So next slide here. Again, I wanted to give you a little bit of a view under the cover, right, in terms of how we do all this mapping. So Epic, we published all of the mappings that are available out of the box. So here is an example for our food insecurity domain. Once again, those question and answers are mapped to the LOINC codes. And these are the LOINC codes that Gravity recommends using for each of the domains that Gravity covers today. Now, as we look forward also, I wanted to share what this looks like in terms of once you are in the chart, right, inside the EMR. If you do one more click, we go to the next slide here. We use this concept, what we call the SDOH wheel in Epic, and what you see on the right side of the screen here for each of the domain that an organization decides to support, we show an overall risk level, right? Could be green, red, yellow. It's gray if the patient has not answered the question. But I wanted you to focus also on those badges, right, that can appear on top of each domain. And so that umbrella icon within Epic denotes information that came, for example, from a payer. And so we have different badges that can appear on top of these domains to indicate that the data came from an outside source from your own health system. And so this is, again, important to understand where the data came from and how possibly to interpret that data as well. Yeah, next slide. Thank you. It's also in the space of SDOH, right? I'm sure most of you are familiar with the fact that there's a lot of regulatory reporting requirements that are either already in place or about to be implemented in 2025, 2026 as well. So I think for the purpose of this call today, as we have Humana presented HEDIS measures and capturing SDOH information in the context of specific HEDIS measure is one of the critical points I wanted to cover. So we as Epic are doing development to make sure that we can allow organizations like Humana, but also health system as well, right, to make those HEDIS calculations within Epic. Again, leveraging those mappings that I said before, so both in terms of screening and intervention as well. HEDIS is an example of a program where intervention play an important role as well. If you can click to the next slide, just looking forward a little bit, again, as most of you might be familiar here, but in 2026, as new US CDI versions are becoming used more and more, there is also needs around new data classes, right, that need to be supported. So in general, Epic and our development team tries to stay on top and provide support for these evolving regulatory needs as early as possible for the Epic community as well. Now, you can go to the next slide. Thank you. We as Epic are very much plugged in also with Gravity. We participate regularly in some of the meetings, right, that Corinne was highlighting, some of the terminology, implementation work groups as well. And certainly we want to collaborate and provide our expertise there. So we are very active in also, like I said, participating in these initiatives, and we want to implement the latest and greatest in this space. So Epic fully supports FHIR specs around SDOH for all the data classes, right? So whether it's a matter of exchanging SDOH assessment data, SDOH problem or health concerns, SDOH goals, and SDOH intervention, right? And for each of these data classes, we have done the work of mapping the data to the appropriate code set, right? So that for our customers, it's easy to adopt these tools and technologies out of the box. And then, like I was saying, participating in Gravity for us, it's also very beneficial because Gravity helps a lot with defining some of the how to think, right, around some of these spaces. And specifically for intervention, I think it's always challenging in the space of SDOH-related intervention to clearly define what counts as an intervention, right? So we always refer back to this Gravity intervention framework for us to categorize actions, right, that our end user take into the system, and again, try to map those actions to specific codes that once again help facilitate the data exchange. So the documents like the one they are seeing on the screen that Gravity put out play a very important role for us to make sure that we make the right choices, right, in terms of how to move forward together in this space. I also wanted to give you, if we go to the next slide, I wanted to give you a little bit of insight into what it looks like in Epic to do an intervention, right? Because we talked a few times about how critical these workflows are about trying to help patients. And so users in Epic have access to what we call a community resource directory that allows end user to look up resources that are appropriate for appropriate for helping patients for the specific needs that they are experiencing around social drivers of health. One more click, please. And this type of activity allows our end users to, first of all, automate the selection, right? We can do some automatic filtering based on the type of services and that are provided essentially by this community-based organization. But then equally important, I'll say we are able to communicate with the patient, right? Whether it's through text messages, email, or through the patient portal, these recommendation or referrals to the patient themselves. Now, if we go to the next slide, also, I wanted to cover, we have spent a lot of development effort over the last couple of years also on achieving what we call the closed loop referral, right? So for this intervention, and specifically as Epic, you have a couple of options for achieving what we call closed loop referral. One is using a technology called Healthy Planet Link. Think of it as a web portal that as an Epic organization, you can extend to some of the CBOs that you might have a higher volume with or closer relationship with, and allow them to have a login and access right to your Epic system to do the back and forth communication. But also Epic and some of the major vendors in this space, for example, FindHelp, Unitas, and others, we have worked on implementing the FHIR-based community resource network resources for us to be able to do the back and forth communication. So you're able to initiate a referral in Epic, and then the CBOs, without having to have access to Epic, right? They could be using for example, the FindHelp portal, and through the portal, by taking action in the portal, the communication back to Epic can happen through, again, those FHIR resources. So vendor agnostic, really. But allowing this, again, closed loop referral that really help care manager, right, and social worker to understand how effective those interventions are. And before I pass it over to Humana, the last thing I wanted to mention, I mentioned the NCQA HEDIS measure, right? And so I wanted to go a little bit deeper because a lot of our customers, right, that work in value-based contract are interested in supporting these HEDIS measures around social drivers of health. And so, again, as some of you might know, we are able, again, to send those screening information, like I said at the beginning, with the mapping to loin codes. And then one more click here for intervention. Once again, we are mapping all the interventions to the Gravity framework, so that we're able to exchange, right, those intervention information with the payers, so that right, if a payer has to then compute the appropriate numerator and denominator for this HEDIS SNSE measure, they're able to do so with data coming from health systems. So this is an overview of what Epic does in terms of implementing and enabling interoperability around SDOH. And now I'll leave it to Humana to jump in and share with you how they are leveraging, right, this technology for specific programs.
Corey, I saw you had your hand up if you wanted to jump in with a
Thank you,
question.
Corinne, and thank you, Matteo.
Yeah.
Corey Smith, the technical director for Gravity. A question about your about Epic's implementation of which version of US Core does Epic align with and support? And second question, do you specifically support or align Gravity's, implementation guide, and if so, which version? It's clear you're aligning with US CDI classes for the Gravity, some of our closed loop referral models and the terminology, but really kind of a specific question about the degree to which you actually implement, RIG, or if you're mostly kind of US core, but using Gravity terminology.
I would say we are mostly US core using the Gravity terminology. I can actually, Corey, find out the specific version. I can send you maybe a chat message here in just a minute. I'll look that up.
Great. Thank you, Matteo.
And then
yeah.
Sorry, I'll take just a minute here for a couple of other questions I saw in the chat so that we don't lose them. But Lucy, I see a question. How do you collect and keep updated the community resources, right? It's a vast universe for sure. So what we do, Lucy, there is we work with health system decide to work with a specific vendor, right, most of the time, and they are able to import the list of resources provided by that vendor in Epic. We have processes to do that, and so that's what end users will be able to select from. And then I see a question from Lisa. What if the CBO uses their own system of record and wants to receive the referral through that system? Again, Lisa, what we have done again with some of the vendors, like I mentioned, is implementing those FHIR-based resources for being able to send a referral. So it would be really a question of if the vendor that the CBO is using is able to support a standard-based a process like a FHIR-based process, right? Yeah.
So if they can, you'd be open to piloting that?
We would be open to discussing for sure. Yeah, there's likely
That'd be great.
Some extra development, possibly on both sides, right? That needs to happen, but certainly something that we could discuss if there's interest. Yeah,
that'd be great. I'll drop my my contact information in the chat.
Perfect.
Any other questions before I move to the Humana section of this?
Yeah, one more, and then we'll move.
Okay.
Many communities do not work with a single vendor for community connection. Mike, yeah, I mean, that's a struggle, right? In the sense that we would need each individual vendor today to implement those FHIR or standard-based exchange to some extent. And so I don't have a good answer for you, short of saying we need to work together to make sure that that implementation can happen.
Yeah, and to echo off what Matteo's saying, and so thank you all for the opportunity to come and speak to you. As Matteo said, I think the Gravity project, I think the Epic team that we worked with, and then there are many others on the phone here today from Humana, both from our health equity team as well as our interoperability teams. And so a lot of work that went on that I get the opportunity and pleasure to speak to, but if you ask hard questions, I'm going to defer to them. Mike, to your point, and Lisa, to yours as well, what we tried to do within Epic in our Humana to Epic integration was really look at, so let's do something so that it's a phase one, right? But right at this point, as Matteo was showing on some of the other slides, it really is, how do we get to bi-directional? Humana has been receiving things in social history, notes for years that indicate, potential social drivers. We've started to see more adoption of the LOINC codes and SNOMED codes and some of those things, which is great. But to the point of what you're all asking and where I think Matteo is going is that we don't believe that one solution is going to work, right? So one of the larger ones that we have talked about is a group like Find Help, right? They're one of many. right? And some communities have them, some communities have none. So our goal is, to Mateo's point, to create a fire standard that can be used by all of those vendors or by a system that has no such community group at all. But getting that closed loop referral is really the hard part, because some provisions exist to make a referral into a system, but not necessarily get the rich data back so that the provider that Mateo's serving information to, or the Humana is making a decision on care management platforms and disease management programs and other things like that, can coordinate amongst the groups. And that's really the promise of interoperability that we haven't had in the past, that I think that we can get away from. And this is really, in today's world, in many cases, this has been my experience, right? There's someone at the front desk who has a clipboard that has all the community resources and the phone numbers written down. And that's might be as good as you get, right? The number for Meals on Wheels is X, and they give them a written down version of that. We'd like to get away from that and make this more transactional, make it more robust and get there. But this really is just a first step. So don't think that any of us, Mateo, myself, or any of the people at Epic or Humana think we're done. This is really just that first foray into what is likely going to be a multi-year journey for us to get there. So we can go ahead and go to the next slide. So from an interoperability perspective, just to give you some background on Humana and who we are, if you don't know, we are a national payer. We have entered into the interoperability space a long time ago, really starting to look at, how would we go get medical records, where we started getting that social history and understanding what's there. But Humana, through other functions and some of the things that some of my counterparts on the phone here do, is we have our own screening programs. We do our own outreaches. We collect information working with provider health systems in different communities to try to get the best information about them. And now what interoperability is allowing us to do is to bring those together. So we originally just started with, how do we build an integration? Then how do we really get to bi-directional? And then how do we get to, there's more than one EHR, right? We were one of the founding members with Epic for their payer platform, but we work with many other EHRs now. And what we generally tell the Epics of the world is, we want you to be payer agnostic. Do not build anything that's just for Humana, because the providers only want it if it covers all the payers. We as payers have to be EHR agnostic, because our solutions need to work with all of those EHRs without custom builds. And that's why things like fire standards are so important, and why the work the Gravity Project does is so meaningful, is because those fire standards will allow us to have that broader scope, where right now we're really just operating in a much smaller ecosystem. We acknowledge that, we know what that is, but we do touch a number of members today. We've got a presence in all of our states, and we have over 200 Epic systems connected today. Next slide. So we've been pulling together data, and I mentioned this a little bit before, right? There were health systems and CVOs, there were HIEs, there were standard assessments like your PHQ-9s, there's non-standard assessments. And so some of the folks on the phone that work in our health equity team, so I'll forget somebody if I try to name everybody, but Christine McNamara and Pete Womack, I know, are both on the phone. I saw their names and know them well. They work to try to collate this across Humana, not just what we do with interoperability, what we do at Humana. And so through a set of business rules and code set analyses, we create this social equity and social impact data store. And we can go on to the next slide. And we're using that to not be Humana's version, or to be Humana's version of your social drivers of health, and how we're using that for the data exchange. We do that with Epic's health plan clinical summary, as Mateo mentioned earlier. But we're pulling in that information for people using Epic. You'll see that come in as an umbrella, and that doesn't mean it's Humana, it means it's any payer. But we'll have the information that we created based upon the previous slide. We'll deliver that back to the Epic system, health system in this case, and then we'll populate the compass rows. So as you see here, the wheel on the right, for those of you that are not related or not familiar with Epic, that is Epic's compass rows, or they may call it something slightly different, but it is an indicator of where there are positive and negative social drivers. So we can go on to the next slide. It goes into a little bit more in depth. So we really picked 5 select domains that we want to focus on, right? You can read those there on the left. We didn't try to tackle every social determinant because we didn't want to overpopulate and create physician burnout. We didn't want to create so much messaging that people wouldn't use it. We tried to say, what are the most meaningful things? What's the most severe things? And then how can we put that in front of these clinicians so that they can really start to understand where that social driver may be causing abrasion within the health system that they just don't understand, and how can we use that to foster trust that we're trying to help them with their health outcomes, to get their best health outcomes. We can go on to the next slide. And so in doing this since mid-February, right? So realistically, we're talking about in a couple of weeks. We went live with this late last year, and this is data compiled through a couple of weeks ago. We had 900,000 outbound clinical summaries. And if the social driver data was available, it was included. You had 100,000 inbound social drivers that we're getting from Epic and other EHRs that we're sending on to that Humana centrally controlled health equity and social impact database. We've got over 50 groups connected. So of those 200 plus Epic groups, there are 50 of them that are currently using this solution. We're trying to scale that as quickly as we can, but it does require people to turn on that health plan clinical summary capability from Epic. And we're really starting to try to understand the value, right? So how can we use this value and really understand what's the impact to members and patients to see their best outcomes, that builds that trust, that creates those, meaningful moments with their providers, with their community resources, and how they would do that. We can move on to the next slide. Yep, so I thought that was the end of it. That is the end of it. So I'm happy to also do it as Mateo did and ask any questions. And I meant when I said if you ask hard questions, I want to defer it to the smarter people than me that are on the phone.
Yeah, thank you both so much, Glenn and Mateo, and everyone from Epic and Humana who's on the line. Really appreciate you guys coming and speaking to us today. So now it's time for question and answers. So please feel free to either put your questions in the chat, or you can raise your hand, unmute yourself, and we can go ahead and answer some questions.
And so, Matt Bishop, I do see your comment about the 360X SD being a referral standard using direct secure messaging. I like that, but I do worry that that doesn't quite get us all the way to that FHIR integration. So I think it feels like it's a good step in the right direction. I'd like to see us take that and build upon it, whether that be this year, next year, some point in the future, to actually get to FHIR adoption, so that this doesn't become an HL7 V2 type of exchange, but we can make that more FHIR adoption. Corey, I see your hands raised.
Yeah, thank you. And I think this might my question overlaps a little bit with Lamont's in the chat, I think. Can you just explain again sort of the direction of the exchange, sort of what's the input from a Humana perspective, sort of how the information is flowing. Maybe I missed some of the workflow, we're screening here on the Humana side, and then that gets shared with the Epic providers or the data. I just kind of missed some of the directions of the exchanges that are that you're supporting, or what the exchanges are.
What are they today?
Yeah, however you'd like to answer it. Yes.
Yeah, Leslie, you're gonna give a better answer than me.
And I'm not looking for really detailed technical, just sort of,
Yeah.
is it Yeah, thank you.
I think Leslie can give a pretty good overview. Leslie, are you out there? I saw you earlier.
She's on the line. I'll ask to unmute.
She doesn't have audio. That's okay. No problem.
Okay. So yeah,
I can jump in, Glenn. Can you guys hear me okay?
Yeah, go ahead,
I'm in
Anna.
the car, but I can jump in. Hi
Yeah.
everyone. I am with the Humana product team as well. And thanks to everybody for doing this presentation. It's great to see it out there. So it's pretty basic, right? So as Glenn mentioned, we do have Humana care managers that are using what I believe, Glenn, is pretty much a homegrown care management system right now. So they intake, through their own phone calls and outreaches with the members, they're intaking and documenting essentially Humana data for the social driver screenings. We also do get social driver data from some of the other EMRs, from Epic themselves via those CCDAs. And so that all kind of comes into a central data aggregation repository. So both those external and Humana performed assessments. And so then right now, kind of back to that crawl, walk, run concept, we are just pushing those assessments that we know about that are in the high risk category out to the Epic EMRs. Does that help answer?
That's perfect. That's just what I was looking for. Thank you.
Yeah, and as Pete was answering in the in the chat, there are a number of ones. So some of them are the standard PHQ-9. Some of them are more homegrown that are part of care management programs we have. So we try to take all the different ways we can get it, whether it's from an EHR provider or from some other function, and normalize that as much as possible. Patricia, I see your hand up.
Yes, hi, thank you. So I work with the PASSIO project group. And so our focus, of course, as you may know, is functional and cognitive care. And so one of the things that I've done for the last 25 years is I work on the classification terminology side for the World Health Organization. So I build out the ICD updates and ICF and our newest, which is our health intervention ECHI classification. So there's obviously with the ICF, we've been able to make recommendations that are going in with our implementation guides for coding functional and cognitive care and status and care to the ICF. But the ICF, when we built this, 20 something years ago, we, and this predates WHO social determinants of health, we created the environmental categories and codes. So does the Gravity Project also look into that? Because we know fire has adopted ICF as an official terminology now. So it would make sense in terms of the interface. Are we now crosswalking and linking a lot of what we see in terms of the social drivers of health to the ICF environmental codes?
That's a probably me level concept. Hi, it's Sarah DeSilva.
Hi, Sarah. Thanks. Yes.
Hi. The answer is yes. We do look to ICF for crosswalking.
Awesome. Okay.
There's a lot more work we could do there, and but yes, that's part of our analysis of what's out there to consider, make sure that we're not duplicating and integrating to international knowledge models. 100%.
Yeah. Thank you, Sarah. I certainly wasn't smart enough about this subject to answer that question.
Appreciate it. Thank you.
Any other questions, comments? The call to action I would have for the Gravity group as a whole here is, I think Mateo and I could both agree that we would be happy to come back and present some findings once we get farther in to see how it's impacting it, more so than just the transaction volumes, and put some real world implications to this. Like I said, we're not done saying that that what we've done is enough, right? We're doing this with Epic. We tend to go to market with our new products with Epic first, just because they're a really good partner and somebody that we work, my team and Mateo and the folks at Epic work very closely together on a number of different initiatives. So this is just one of what's likely to be 10 or more this year that we spend time working on. And each of them are in various states of maturity, right? Where some of them might be proprietary and we're trying to move to fire. Some of them may be, we're just trying something to see if it works and we're trying to do it on a low fidelity method to, prove out that there's value to it, because, we can't, neither organization wants to put a bunch of money into, bulletproofing the process when we don't have quantifiable numbers, because all of our companies are still run by accountants. So those are the kind of things that I think the call to action would be: your all's ideas, continue to get them to the Gravity team, to Sarah and others. And, they can work with us directly, and we can try to figure out how do we do that. And then as we participate in Gravity, the folks on our teams that are regular Gravity participants will certainly be there to contribute as well.
Wonderful. Any other questions from either of our presenters today?
I'm going to say thank you. I can come on camera here for a second. I just want to say thank you so much to our friends at Epic and Humana for representing the application of Gravity terminology and standards towards common goods. I always get a little bit emotional in implementation meetings, because the things that we conceived of to solve collective problems and tell critical stories are now being applied in real world solutions across millions of lives. So just thank you so much. And just the theme of the implementation of Affinity meeting is user feedback. So as Corey was stating, and I just want to reiterate that the team at Gravity is always wants to make sure that what we've built meets your needs and purposes. So please send us an email at any time so that we can ensure that we're collectively crafting standards to address these common needs. So thank you so much, Epic and Humana friends. It's so exciting. That's all. That was my no question. Just a thank you.
Yeah, no, thank you for the opportunity. We certainly like to to get out and share what we've learned and what we are learning. This is a journey. I don't think any of us are done yet, but this is we've made a significant enough progress that it felt right to come in front of a group like this and talk about it. Lucy, I see your hand up.
Yes, thank you, Glenn. That image of the circle of domains, and then the domains that Humana chose. Thank you. How did you choose the domains that you chose? And what is your perspective on adding domains?
So I'm going to call on Christine or Pete from the Humana Social Equity or Health Equity and Social Impact team, because I think that they're the ones that had most of the influence there on which ones we picked.
Well, you'll probably hear Pete and I partner on this answer, but we started with at least the first three. That was part of the social needs screening and evaluation measure, but also because Humana had an interest in social connections and financial resources. We also included those in there as well. It was kind of a continuation of our bold goal efforts and healthy days measures. So we started with what we were looking at were the standard 5 that included financial resources, and then you can go a little bit deeper into there. But Pete, I'll defer to you if you have anything else you want to add on the domains.
Sure, thank you. Yeah, we have primarily focused on SNSE as well as those 5 domains. There has been talk of utility help. There's been talk of partner violence, but we're still exploring those and trying to understand how much value they would bring to our members if we were to track those. But it really right now is just focusing on SNSE and the big 5, as I call them.
Thank you for those answers. If I'm thinking about colleagues or policymakers who don't know anything about this, the question always comes up, what is the evidence for intervening here? And is the evidence strong enough that intervention will be a positive thing, is that evidence strong enough to fund it? So that's why I asked this question. And I really didn't hear either of you say, well, this is all data-based. So I'm wondering if one or both of you could just drill down a little bit. Is there enough evidence for interventions in these red realms for you to justify Humana going to work on this? Because as Glenn observed, accountants run your organization.
I will say that the ROI is always in the background, and that's something that we always have to justify internally. There is data, there are published papers that indicate the effectiveness of programs in other areas. There is also internal data to Humana that indicates that we do make a difference. Part of the problem is that we're talking about relatively small populations within the entire Humana universe, millions of members. And it requires a certain comfort level with spending resources and time and money on a small group of members within the much larger group. Now, for me, that's a no-brainer, because part of the reason why I got into social health was because I want to be able to speak for those members who are not heard amongst the millions of other voices demanding things from the payer. But realistically, there's always the question of that balance of whether we can justify the cost of paying attention to several 100,000 members, and what is it that we can do effectively with the limited resources that we're given that we also have several million other members that we have to pay attention to as well. It's a delicate balancing act. We use a lot of data. We do a lot of thinking and considering and generating policy and insight to help guide us.
Thank you
Yeah,
very
the
much.
one thing I would add on to what Pete said, Lucy, is Humana, while we certainly are looking at ROI and looking at those things, there are what we would refer to internally as big bets, right? So big bets that we're willing to take that says, this is the right thing to do, but I can't prove it to you yet, Mr. CPA, right? And so what we do is we try to do this in very small settings. That's what Christine and Pete have done in many occasions directly with certain communities, right? So we have a different arm of Humana that's part of our foundation that works with this community or that community on different social needs. And every community is different, right? So they might not even use these same 5 because community picks something different. That's not to say that automatically makes it easy to make it interoperable. And so part of what we've done from an interoperability perspective and with a partner like Epic is to say, okay, they built a pipe for us to push it through, right? The health plan clinical summary. We have the data available because of all the work that Christine, Pete, and many others did for a long time to pull that data together, whether it's coming from an Epic EHR, somebody else's EHR, a non-standard screening, a standard screening, doesn't really matter. That's why we're normalizing it. And then we're pushing that data back. So if the Epic providers are only seeing the social drivers that the Epic community is documenting, then they're missing the boat. And so we're trying this on a, not a full scale, right? We've got, what was that, 50 connections, right? So I won't say it's small, it's significant, but we're not trying to go to 100,000 providers overnight because we honestly don't know that we could handle the volume and we can't prove that it's worth it to be able to put that kind of capital behind it. So small test and learns, even though 50 provider health systems isn't quite small, but it's small for us.
Thank you, Glenn. I think Humana should be congratulated on accepting the proposition that this is the right thing to do. I'm sure that everybody on this call has been in a situation where we know it's the right thing to do, but persuading the powers is another matter. So it sounds to me like you're really on the path of doing that. And that is really just as important as all the technicalities that you told us about. The idea that there's enough to go on to make the right thing to do happen. It's a risk, but it has
Yep.
to happen. So thank you very much.
Yeah, I mean, and sometimes it's, stars gaps, and sometimes it's less phone calls, and sometimes it's, avoided hospital stay, right? I mean, so it's, you guys understand healthcare, and it's hard, right, to tie, the chaos theory of what causes medical costs to be what they are. But this certainly feels like the right thing to do. So I applaud Christine and Pete, and I'm happy to work next to them to the work that they're trying to influence, whether it has anything to do with interoperability or not. And I'm happy to be part of of helping them try to solve this through partnerships we have with groups like Epic. And Jonathan Kraus, I saw you had your hand up. Did you want to ask a question?
It's not necessarily so much of a question as it was a statement, but I think you guys have all kind of touched on this, so I don't want to be redundant, but I think that from a private sector commercialization, commoditization standpoint, right, like most insurance companies operate under the theory of adverse selection. And so the ability to predictively analyze what could potentially happen to anybody that potentially falls into a vulnerable risk category, because just because you're not a vulnerable population demographic right now doesn't mean you won't become one at some point in time in your life. But the ability to effectively treat those conditions and have the information that allows you to make decisions prior to that happening, I think will help the adjusted cost benefit analysis for a payer in terms of any covered lives that they may have that might fall into a vulnerable population. So I would just say kudos to the work that you're doing to continue to kind of keep pushing that rock uphill. And then eventually, as people kind of wake up to the realities that this is going to affect more people, then hopefully they start to make the decisions that they allow you to take more ownership and ownership over the process. But that was a long-winded way of saying thank you for the work that you're doing. And I hope that you reach a critical mass where the CPAs come back and say, can you give us more evidence to support why we should do this?
Yeah, no, and we're certainly we're certainly feel like we're making progress towards it. So it's not just like Sarah said earlier, right? It warms her heart in that this work that all of you all have been doing for a number of years is finally coming to fruition. We couldn't agree more, right? And that's why we participate in groups like Gravity, is because we want to take that. But to your point, Jonathan, and to many of the other conversations that have been going on in the chat, we do often partner with Epic first because we found that they're the easiest for us to do this sort of test with and prove it out. But we are truly, we want to be vendor agnostic, not just the HR agnostic. I don't care who's integrating to get this data. If the patient says, if this is put the member at the center, the patient at the center. If the member says, I need help with my ride, who can help me? Is that the community resource? Is that their Humana Medicare Advantage benefits? Is it, something else? I don't know. Right. And so until we get all of those things interconnected, we're just never going to know.
Well, but that's the opportunity, right? And so when you think about the ROI metrics and potentially like the target market that you're trying to serve, like, and Lucy, please don't beat me up because I know you always get on me about talking about technology, right? But that's where like leveraging emerging technology, like predictive analytics through artificial intelligence, like you can do that potential modeling to say, if in fact this were the case and we wanted to scale this for these people in vulnerable populations as it relates to SDOH data, like what would that look like? And it makes it easier for a bean counter to get their head around that, because now all of a sudden they don't have to like sift through like miles and miles and miles of data to aggregate it, but you can literally put it right in front of their face, and then you can put a cost benefit analysis around that. And makes it easier for them to consume what it would look like to eat the elephant one bite at a time. And with that, I'll put some more air back in it. But thank you.
Okay. All right. No, I appreciate it. And again, thank you to Gravity and all of those of you that gave us the opportunity to speak on this today. And as I mentioned, and I saw that Sarah said that she would like it. You all can certainly circle back with us later this year to come back and share progress made and what our next step is. I know that Pete, Christine, Leslie, Anna, all the people on the Humana side are extremely passionate about making this work. So we're not doing it because it's just a check on the goal. We get lots of bean counters wanting us to get lots of things that make money for Humana. We want to do this for the right reasons. So that's why we're all here.
That's wonderful. And Glenn, thank you so much again, and the whole Humana and Epic teams for presenting today. This has been a great conversation. Really appreciate all the active participation in the chat and verbally as well. This has been awesome and definitely sounds like there is a lot of interest for us to circle back with these folks once they start getting more information and some results. So we will definitely be doing that. And thank you all so much again. I believe if there's no further questions for the Epic and Humana teams, I'll hand it over to Sarah DeSilvi for our community office hours, and we will go from there.
I'm in the hot seat now. Glenn, you can pass the torch now. So I actually am here with Corey Smith, the technical director from Gravity as well. And we just wanted to make sure that in the grand spirit of supporting implementation, we are here to just, talk about, flip the script a little bit and make sure that we're answering any questions anyone might have on Gravity materials or opening a community moment. Anyone have any questions in general? Incredibly grateful for Amy. Hello, Amy.
Hi. You know what?
Hi.
Hi. You know what I'm going to ask.
Oh, okay.
And I'm going to, first of all, thank you for doing this. It's so helpful. It's all still kind of a swirl of acronyms, but every once in a while, one of the swirls slows down and I can land on it and recognize it. So anyway, what I want to know is, my understanding of the digital literacy and access terminology is that those two concepts have been agreed upon, and some of the definitions have been worked out, but there still needs to be work to define patient goals and services that get provided and the service providers and the kind of services that are provided. What is the roadmap for that happening?
I'm happy to answer this question as best I can. For anyone who doesn't know Amy, she and I got to know each other when we were doing our digital literacy and digital access domains, and she's an amazing expert. So on digital literacy and digital access, we're still trying to actually get author permissions. We're searching desperately for author permissions for critical instruments that need to be encoded in order to fill the gap in instruments there. And Amy, if you have any contacts, we would love to maybe connect you into that. That's an ongoing area of need.
Let me know which instruments you're talking about.
Love it.
So yeah.
Love it. Yeah. Okay. Consider yourself in the grand community initiative. And then regarding other areas and concepts, every SNOMED release is another flux of different concepts that are coming into the ecosystem. Regarding the helpers, there is a little bit of one of the things that we're working on right now. We have a meeting regarding this tomorrow. Is ensuring that some of the critical community care, social care roles that exist in the community are represented, if possible, within a taxonomy called the National Uniform Claim Commit. So the NUCC, Corey Smith, maybe you are remembering the last C there, but we can't create a refer to blank role within SNOMED and for Gravity terminology, unless that role is a thing that's defined within this health, this role taxonomy. So we're working on that as well. Digital navigator is a critical role gap there as well. There's a whole bunch of navigator concepts thank you so much, Sue Bowman. Thank you so much. Yeah, so part of you sometimes in order to fill terminology gaps, we actually have to work and leverage with other classifications and taxonomies for things like core roles and purposes. And then after that's established, we can come back and do SNOMED and HIT term, if that makes sense. So digital navigator, housing navigator, all those kinds of very critical social care role types are part of our advocacy with NUCC. But we will reach out to you regarding trying to get those permissions for those digital literacy and digital access instruments. And the rest of the concepts should be blooming soon within SNOMED releases.
Okay, because I'm super interested in the navigator roles
Oh,
piece
yeah.
of it. So
Yeah. Yeah.
I don't know if that's something I can get involved with now, or if I wait,
Oh.
if I'm supposed to wait until it percolates.
What I will
some
do
more.
is I will include you in making the case to NUCC for the role.
Thank you.
Okay.
Okay.
And that was an example, friends, how sometimes terminology is like basic modeling of community activism, because in order to do the concept, we need to do this other thing first. And so we're working on solving that again with NUCC, and that our work with the National Uniform Claim Committee and their health provider taxonomy is partly in response to a request for information that came out from CMS last year, asking for critical social care role concepts that were important for reimbursement and social care to be developed, and we're working on that as well. Okay, that was a long answer, Amy. I hope I answered your question.
Yeah,
Okay.
no, I'm scribbling frantically. Thank you.
Okay, great. We'll reach out to you. Okay, any other that was incredibly nerdy. What happens when you open up the the community office hours? You know, anything else? Anyone else have any questions? Someone can hit Corey next. Ask him a fire question. Anyone have any other questions? We want to make sure that we answer your questions while we're here.
And maybe I can pose a question that might raise questions, because I think it sort of came up. I think it came up in today's call with Mateo's answer, and we want to poll the audience a bit in terms of, you know, in Gravity we think about tiers of implementation, and they're not sort of better than each other. They're just sort of three tiers. So we think of tier 1 as being just implementation of Gravity terminology. We think of tier 2 as being exchanging that Gravity terminology by any means, except for fire, you know, so CDA, V2, facts. And then we think about tier 3, which is exchanging Gravity terminology using the Gravity implementation guide. I think I think when I hear Mateo's answer about Epic's implementation, I'm wondering that, you know, where there are implementers who are primarily focused on implementing US core FIRE's US core implementation guide with sort of Gravity terminology, right? Which is sort of a little bit different than implementing the Gravity implementation guide specifically. And there's no judgments about that. This is the real world and how people do things. So I guess I'm curious to know if others are, you know, exchanging Gravity terminology using FIRE, but not the FIRE, you know, the Gravity implementation guide, or more the other side of that coin is, you know, are there folks that are doing full exchange of Gravity's terminology using the Gravity implementation guide? That was a lot of questions.
Corey, you need to have a hackathon to find that out.
We do, but I ask everywhere because we don't always find it out there either.
Okay.
Thank you, though, Lucy. You can think on that. Reach out. I'll put my email in the chat if anyone wants to reach out and talk about that.
Mike and Lisa, what about the Michigan situation? There we go. Lisa's already commenting. Lisa, can I call you in, my friend?
You can.
I'm calling you in. Good. How are you?
Doing just fine, thank you. Yeah, so we're piloting both.
Can you talk more about that? I know I'm really curious. I want to know more because you're so smart. Talk to me.
Like, not really, just like a pain in everybody's butt. So we are working with several vendors in the community and several vendors in healthcare to be able to pilot both terminology and the fire IG for referrals to get a truly interoperable referral. But we're also doing that based on the community co-design work. So it's kind of marrying all of what we've learned over the last like 3 to 5 years to kind of pull it all together, driven largely by community. But what we're seeing is that the healthcare spaces are really recognizing and seeing this problem. They're seeing this problem both in Michigan and playing out nationally. So we're kind of hitting the same wall. So we are very much hopeful that this will kind of get some national attention.
Do you
we are not
Lamont asking you?
Sorry, go ahead.
We have our friend from Manat, Lamont, I see you. You just asked Lisa a question. Are you doing it for HRSN screening information is the question?
No, so like we're using, you know, LOINC codes in that. We're doing that, but really and truly, you know, I'm a nurse. And we have there's a lot of value in the data itself, but to be able to pick that up and move that about the environment in a fire-based pathway, when what we're really trying to get down to is what are we doing about the actual screening itself, and really kind of trying to put the emphasis less on screening and more on you know, how are we connecting with community? How are we doing it in a way that's not destroying the community environment? And you know, it's funny, I see Richie Welton on here. Richie.
Your friend Mike also has his hand up, so you have good company.
Yeah.
Thank you so much, Lisa. That's really helpful.
Thank you.
Yeah, I can fill in a few
Yeah.
of the blanks here. I think we had a fairly good experience in MyHIN of getting many organizations to do health-related screening stuff. But we started this in the time before there was a gravity standard in place. And so when organizations start to do something in a certain way, getting them to change how they do things and then adhere to standards is a long process. And I think across the field within Michigan, and especially given the need to get community organizations on board and actively participating, we felt like the strategic play was to get organizations to work with what had value to them, and that's sorting out the referral process and who actually is commissioned to partner in doing social care. So the health-related screening needs and the standardization of that to LOINC codes is going on, but we're not focusing on exchanging screening data yet because the plans that have wanted that screening data are still getting it in the form that they're using it. So it's just a matter of trying to get priorities right and getting the idea of a message that can establish a referral between health and social care in a way that's interoperable so that people use their native technologies seemed to be the play that we needed to get done right. And then we're running into all those things that you saw in the chat today. We're running into things like what Matt mentioned, that different organizations use different standards. So getting people to test fire when they're barely electronic is a big lift. So we're also trying to figure out how to use things like direct secure messaging when you're out in your second or third tier of community to get food delivery under the Michigan ILOS arrangement, for example. So all those things, we're trying to be as practical as we can, but make sure that when we embed things, we're following where we can the implementation guide for SDOH that's in fire, and pointing out when we can't follow it because it's not specific enough or the resources aren't correct for those messages. And so we're actively working with the HL7 team on that.
I will also say, you know, based on our you know, screening information via fire, there's, you know, MyHIN's been doing, you know, quality measure data delivery for really some time. So we're really kind of looking as to how do we modernize that data flow right now. But payers, given everything that's going on, they kind of like how things are done now. So trying to update that data flow has been a bit of a challenge. So I think that the effort that we really want to expend right now is in kind of connecting health and social care and defining those those use cases, defining the right technical standards that work for both sides.
Sorry, that's a pretty good answer to your question.
I'm glad we could help.
Matt, are you building off of Corey's question to the community? Is that your thought, or a different question?
I was going to go in a different direction, so if you want to let
Yeah.
other people respond to Corey, it's fine.
I think this is the purpose. Open office hours is open hours. Let's do it.
So I was wondering if there has been any headway or progress on kind of standards adoption within government agencies that process like program enrollment,
Oh, yeah.
right? SNAP, WIC, that kind of thing, and the kind of unique workflows in that oftentimes it's like the multi-hop issue where there's navigation, referral to navigation to enrollment, and there's the submission of the actual application itself, and then there's the status of the the program. So any updates on?
I would say early updates and hope for focus in 2025. And Corey Smith, I don't know if you're still with me, but I might call you in for a second. But like one of the things that we learned from the Social Care Voice Co-Design Initiative are those bleeding edge health and like federal entity interoperability requirements. Like I think about those entities that require clinical and social care interoperability that are funded by regulation. So not necessarily SNAP, even though SNAP is, I'm a food insecurity girl, the SNAP vaccine, ever so critical. It is foundational. It's called the vaccine for a reason, because it like underwrites like health and stability for families that are enrolled in it. But really remember, for anyone who was read the report, WIC interoperability was a really critical like use case for us to lean into. And there are lots of different areas in the country that have they're leaning into interoperability within standards between WIC and social care entities, because within WIC you actually have to clinical entities have to prescribe services that WIC offer, as you know. So, and then also with housing, because of, clinical involvement in eligibility enrollment in HMIS programs. So our eyes are like laser focused on those kinds of use cases for like 2025 and beyond, and really built out of the Social Care Voice co-design question, and built off of the members' desire. Gravity does, we're a membership, really to drive towards outcomes, like outcomes oriented documentation is the call, is our charge within Gravity. So just want to note that yes, there's lots of great existing interoperability examples with the WIC and clinical care entities. Civitas just had our friend Civitas just had a great LinkedIn post regarding some work that's happening in California regarding that. I know there's work happening in Vermont for the same. The National WIC Association spoke to it last year, in the Social Care Voice co-design that's ripe for that kind of enrollment-based interoperability. And then our housing friends are asking us for the same thing. And then in general, supporting standards for eligibility enrollment is something that Gravity is looking at very closely. And Corey, I hope I set you up for success.
Yes, so I'll just add just a couple, just very specifically on, what's on our STU3 roadmap as it relates to enrollment and eligibility for the implementation guide for Gravity, is very specifically on how do we exchange someone's enrollment status. So I'm enrolled in XYZ programs, and how do we sort of exchange someone's eligibility status for programs as opposed to full on interoperability to enable enrollment and enable eligibility checking. We think those are important, but those are harder problems. And we think that these are sort of lower hanging fruit that will add value to the things that Sarah mentioned as it relates to outcomes and other things.
I agree that the full-on logic is its own beast. And then the other area in terms of just that could be of increasing importance in the Trump administration is the required documents. What types of documents? Again, that's its kind of own level that could stand aside from. So even just representing a consistent way of of what types of documents are meeting what factor or something, but
supporting documents for intelligent referrals is definitely something that we are laser focused on too, Matt. Again, anything to like ensure that when we're sending patients to to connect with services from any entity, social care entity, clinical entity to social care entity, that we know that some programs always require X. It's not dissimilar to how when I send a patient to a consultant in a clinical space, I know that consultant always requires X. And so my referral package has all the things that referral requires. So we are again from a point of trying to move towards measurable outcomes. That's something that we're exploring as well. I hope I did, Corey, a good job. Is that correct? Did I do
Yeah,
that right?
no, that all that, and just like you triggered when you said documents, Matt, it triggered something that we have looked at in Gravity is, we have some document references, but we're looking at LOINC. LOINC has a classification for document types. They have terms and codes for document types. And I think we've identified that there's opportunity for expansion in that area to better just standardize the types of documents that are needed for social care delivery and enrollment and eligibility and all those things. So you're just triggering something that has come up recently that I don't think is on the roadmap currently, but it's sort of on the backlog awaiting prioritization, I would say.
Yeah, and that's one thing that we're working on. Corey just reminded me of that in our enhancement cycle within terminology, is querying the community for missing social care program document types, so we can work with LOINC on creating concepts for them.
Great, thanks.
Sorry, that was a lot of words. I just saw a question regarding, as I work my way through digesting the Gravity SDOH social care ID. Hi, Jennifer. If you have a question on a profile content or value set, who do you contact for clarity? You can always email gravityproject@hl7.org, but also come to our technical public calls. We would love to have that. Corey, am I correct? We'd love to have questions.
Please, everyone, all of you.
Yes, please, everyone, all of you, all the time. So Wednesdays, I'm going to try. I think we put the link. Yeah, I think we put the link for meetings. So the technical calls are Wednesdays, 1 to 2 Eastern Standard Time, alternating every other week, and they're available on the HL7 conference call calendar or just in the Confluence and Gravity. I'll put the link in there in a second. But we would love that meeting is public for a reason, the same way terminology meetings are, the same way these meetings are. We want you to come and ask any questions you need to, or you can ask it now.
And Jennifer, I have a question for you. You're focused on some of the Canadian implementation of Gravity's work. Am I connecting you with the right work?
I think so. Yeah, I'm with the Canadian Institute for Health Information. Kind of new to the group, but I've been also facilitating a working group through Canada Health InfoWay for a couple of years. And Sarah, in fact, you presented to that group a couple of years ago, and Marcy was the facilitator. So yeah, I'm just have a new hat, but doing some of the same work, but very early stages, but very much looking at the Gravity IG and our full suite of a healthcare standard that we're calling the Pan-Canadian Health Data Content Framework, and a subset of that being the CACDI, has ESTO elements in it. So yeah, we're just plugging away and trying to cover the data elements and value sets, and our work is more the what, and we hand it off to InfoWay for more finessing with the FHIR translation, if you will. But if the closest we get it to being FHIR aligned, then it just goes further faster. So that's why I have my eye on all that.
And Corey, this relates to the fact that in whether it's working group meetings or other entities, Jennifer, when we think about, there's many other countries that are now coming to Gravity and saying, we want to replicate Gravity for Argentina, Gravity for Peru, Gravity for France.
Chile.
Yeah. Australia. I want to note there's for very clear reasons because of our ongoing connection. There's some conversations happening at the HL7 level about Canada and US partnering on that. I don't know if that is what just know that we at Gravity are talking about that too and how we can help.
Fantastic. Okay.
I know. Exciting.
Sounds good. We'll yeah, we'll probably connect more and yeah, just appreciate this group, and I'll try to key into some other resources and other calls too.
Great. Okay. I wondered whether office hours was going to be a good thing, and this is really fun, I have to say. It's the point of having it. So anyone else have another question? Jonathan, I saw your hand up. We have a few more minutes, and then I believe we'll close a little bit before the top of the hour so that I can flip to go to the Gravity Terminology meeting.
I just have a very naive question. Have we stopped to consider that maybe, well, first of all, we know that there are more laggards than there are innovators. I mean, that's just known, right? Have we considered that maybe people are slow to adopt some of these things because they don't even necessarily know what to do with the data once they have it?
Is it, that's a good question.
There are lots of barriers, I think,
There's
to
so many
adoption of the
barriers.
standards, and I think I don't know all of them specifically, but that seems like possibly a barrier. What to do with the data? So I mean, I think that's downstream, but yeah, I think that seems plausible, but I can't say for sure.
Yeah, I can speak from the Humana perspective as we've talked to certain provider groups about doing this with our, that are using the Epic software, is that providers themselves, so not necessarily their office staff, they're like, look, if you want to put this information in front of my office staff, great. But I took the Hippocratic Oath, and the Hippocratic Oath says if I know that this is a problem, I'm supposed to do something about it. And so if you tell me about their transportation issue, then now all of a sudden I feel compelled to do something and I don't have the time.
No,
So
and that is absolutely, I'm not saying that it's right, but I commend them for being that transparent about it. But I think that that's where being able to offload the work, the administrative work that they're doing, to allow them to focus more on patient care. Sarah, correct me if I'm wrong, but I think that ultimately that's where we're going, right? To get the right services to the right people at the right time.
Okay. Can I butt in there just because I do want to raise the issue that they can offload that information or those tasks onto, staff within the healthcare system, but it's ultimately the community that is servicing these folks. So I would agree with you that partnering with the community and making sure that the community and those organizations are recognized as a part of the care team is 100% the right activity to allow medical care providers to remain focused on the decisions that they and only they can make while still caring for the whole individual.
That's right. That's exactly right.
I'm going to just try to offer a few things of wisdom. The good thing is Gravity doesn't have to address all of the things in the world. So I want to put.
But I do believe that it is this body's role to raise the issues.
I was about to. I just want to, as much as we have boundaries, I want to note that there's 2 resources I put in the chat, which is the Siren Logic model for addressing social needs, which is really lovely, and it was updated last year. It's a really good resource. And then the NCQA resource on cross-sector partnerships from the healthcare sector to addressing social needs, that leans into, Lisa, what you were mentioning. And I just want to note, and I know it's a little problematic, but just as social care is not a monolith, neither is clinical practice a monolith. And so those entities that work in FQs and community health centers have never had an option to differentiate social care from clinical care, because by charter we're supposed to, right? I just want to know it's a big world out there, but I just want to note that fundamentally FQs are required to, and have been for decades, to address social needs in clinical practice. So as much as the Hippocratic Oath element comes in, it kind of depends on where you work. A little bit. Lisa, does that make sense? Like, I hope that makes sense.
I mean, I think that it does, but I think that we are also, pretty much every FQHC that I have ever been in contact with or worked with has been the expert at partnering with their community from the get-go. So yes, they are the expert at paying attention to and trying to identify those things, and maybe experts at being able to connect with community. I would agree with that statement.
That NCQA brief is gorgeous. These cross-sector partnerships and how to model them is a lovely brief to disguise the work of just that. Okay. Woo! And if anyone hasn't seen the Siren model, it's a lovely model that does a really good job in talking about the role of clinicians and community health workers and team-based care and acknowledgement. And I'm going to pass back to Demery to close us out, I believe. I think office hours for this moment are closed. Come to a public terminology call, starts in 5 minutes. Ask your terminology questions, we're always there. Technical work stream happens at 1. Demery, you go.
Awesome. Yeah, I was just about to say you can feel free to engage with us in 5 minutes for another hour at the, or another hour and a half, excuse me, at the terminology workstream meeting. And then make sure to join the technical workstream meetings. Those are bi-weekly, Wednesdays 1 to 2. And then we will be seeing you all next time. I need to update this last Thursday quarterly. So our next implementation affinity group meeting will actually be May 29th at the same time, 2:30 to 4 Eastern. And then feel free to engage with us. We have our website here, our Confluence page. Our Confluence page is always being updated, so feel free to check back in there. Has lots of great information. We have our Twitter, or X, maybe I should call it now, and our LinkedIn. And again, thank you all so much for being here today. This was a really great dynamic conversation. Appreciative of everyone who was able to join, and we will see you all next time. So thank you.
Thanks, everyone. Thanks for joining.